I'm going to be talking about why electron beam therapy in skin cancer radiation therapy. As Derek said, I'm the CEO of SET Solution and also a board certified radiation oncologist. Disclaimer, I'm not a paid speaker for IntraOp, and like Dr. Casper's presentation, this presentation contains proprietary images that we ask that you not copy or disseminate without written permission. An overview of what I'm going to talk about is our team at SET Solution, what we do. We're going to talk about radiation therapy for non-melanoma skin cancer in general. We're going to talk about why superficial electron therapy, or SET, might be a good choice for your practice. We'll talk about published national guidelines on the use of radiation therapy in non-melanoma skin cancer. We'll talk about the unique SET technology for dermatology clinic that IntraOp has developed. All right, so a little bit about our team at SET Solution. Our company is designed to offer turnkey setup, staffing, and operational management of all SET clinics within dermatology offices. As some of the questions already alluded to, we're basically running a full-service radiation oncology department just for skin cancer within a dermatology practice. And there are a lot of moving pieces to that. And we oversee all of that so that the dermatologist does not have to worry about that and can just practice dermatology. Our services are customized to the unique situation of each dermatology client, and we assist them from site selection to day-to-day operation once running. And we are managed entirely by experienced radiation oncologists, and also have an excellent physics team to remove all the burden from the dermatologist, and we manage the radiation, including dealing with everything relating to the machine and interfacing with IntraOp. And so that's me, that's our chief physicist, and those are some of our radiation therapists next to the IntraOp device. So a brief note on radiation therapy for non-melanoma skin cancer. As Dr. Casper alluded to, it's long been known as an excellent alternative to surgical resection for a variety of reasons: medically inoperable patients, cosmetically sensitive areas, patient preference, which is always a really big one, and then post-operative treatments. In terms of type of radiation, there's several types for skin cancer that can be used. The probably largest type overall is external beam radiation therapy. That can be delivered with megavoltage photons. This is what a big traditional linear accelerator can generate. It can be delivered with KV X-rays, which is what superficial radiation therapy, or SRT, or the census machine can deliver. Sometimes it's also called orthovoltage. And it can also be delivered with superficial electron therapy, or SET, which is what we are using at Dr. Casper's practice. It can also be delivered certain types of brachytherapy, either with radioactive sources or with electronic generated brachytherapy. As I'll illustrate, I think electron therapy has several advantages for treatment of non-melanoma skin cancer compared to the other alternatives. First of all, a brief primer for the non-radiation oncologist in the audience of how radiation therapy cures cancer. I often get asked this by patients, and that is radiation therapy, as it enters the tissue, causes the formation of free radicals, or free electrons, within the tissue it passes through. Those cause DNA breaks in the cells that it passes through. And while normal cells can, by and large, repair this damage, cancer cells cannot, particularly if you do what we call fractionate and break the treatments up into multiple small doses. It exploits this difference. Most cancer cells, even if they're lethally damaged, do not just immediately disappear. They take time to go away. And particularly cancers that grow slowly, die slowly. And so assessing response is kind of a prolonged process that we follow once the treatment's done. But usually the doses we use and the techniques we use have been shown to have very high cure rates. So if you trust the process, usually you get the outcome you want. Our national society, ASTRO, recently published a white paper offering definitive guidelines for the use of radiation therapy in non-melanoma skin cancers, both definitively and postoperatively. And in terms of definitive RT, these are the recommendations and the category of strength. In patients who either medically cannot undergo a resection or decline surgical resection, there's a strong recommendation. And in patients for whom surgery can be compromising cosmesis or anatomical function, RT is conditionally recommended. And conditional means that most people would choose the choice, but not all would, and it involves a informed consent process. And the same is true for not recommended, for patients who have genetic diseases predisposing to heightened radiation sensitivity. These are relatively rare diseases such as Gorlin syndrome or ataxia-telangiectasia. Also, the NCCN guidelines support the use of radiation therapy in non-melanoma skin cancer. The NCCN is the National Comprehensive Cancer Network. It's a consortium of 30 of the largest cancer centers in the United States. And they put together guidelines on just about every type of tumor there is. And they have guidelines for both squamous and basal cell. And you'll note they list the different fractionation schemes that they consider appropriate for both early stage and more advanced stage tumors. Almost all the tumors that we treat with SET technology are on the smaller side. Most of them are less than 2 centimeters, but occasionally are larger. But you can see that there's definitely a preference towards more extended fractionation than what I know a lot of dermatologists are used to using when they use the Census device. Census does not, for whatever reason, promote fractionation as much as a radiation oncologist would. And we are big believers in fractionation because, as highlighted there, protracted fractionation definitely results in improved cosmetic results and also lowers the risk of wound healing complications, particularly in poorly vascularized tissue. The classic example of that is pretibial lesions in older individuals. And so we typically use more protracted fractionation schemes, usually no fewer than 20 fractions with daily fractionation, and sometimes up as high as 32 fractions to doses as high as 64 gray. Why superficial electron therapy in particular? Well, electron therapy has a few physical advantages over KV X-rays as delivered by the Census machine. The first is that at the skin surface, the dose stays higher for longer. So this is what we call a depth dose curve. So the depth of tissue that we're treating is on the x-axis, and the percentage of the full prescription dose is on the y-axis. You can see with the electrons in the blue, the prescription dose is delivered almost to 100% for the first 5 millimeters of tissue, which is where the cancers typically are. We have some degree of flexibility in how deep we can treat based on the bolus we use. But in contrast with the KV X-rays at the surface, immediately the dose starts to fall off. And by the time you're 5 millimeters deep, you already have lost 20% of your prescription dose and are down to 80%. And so the thicker the lesion, the more this difference becomes problematic. Also, on the flip side of that, when you go deeper into the tissue, you'll notice that the electrons fall off much more quickly, such that by the time you're 2.5 centimeters deep, there's really no residual dose being delivered at all. Whereas the KV X-rays have quite a long tail that deliver a lot more dose, all the way through the patient, and will eventually exit the other side. So on a scalp lesion, for example, the brain will receive a fairly substantive dose relative to what can be delivered with X-rays or excuse me, whether what can be delivered with electrons when you're using X-rays. So the brain dose is a kind of a classic example of the deep dose difference and why that's important. Dr. Casper showed this slide, but this is just one example of a patient for whom electron therapy is very useful. Just a few technical details. He had a basal cell of the right outer canthus. He declined resection with Mohs, and so we treated him with 6 MeV electrons as generated by the IntraOp technology. We treated to 64 gray and 32 fractions, which is our standard fractionation for cosmetically sensitive areas. That's 2 gray per fraction if you do the math. We used both a on-skin lead shield and an internal eye shield that allowed us to treat the lesion with very sharp margins, but not treat either his eyebrow above it, and also not treat his eye beneath the eye shield. You see how well that healed and how nicely and cosmetically unaltered and also functionally unaltered his eye is. So he was certainly very pleased with that outcome, as were we. To deliver electron radiation therapy traditionally required a full-size linear accelerator in a full-size radiation oncology department. These are some photos of one. This is a variant true beam, which is the standard, kind of the standard state-of-the-art device for that. These are very expensive machines. They take up a lot of space. They are in a vault that has walls 6 feet thick, typically all the way around and on the ceiling as well. And the cost of all that typically runs about $5 million or so. This machine can do a lot of really fancy things that you definitely do not need for treatment of skin cancers. And also that this machine is so bulky and expensive and requires so much shielding that unfortunately it has kept a lot of patients from getting electron beam therapy as an alternative, just because it's not as widely available as their dermatology offices. It requires more space. It's intimidating to go into a cancer center when you have a relatively favorable prognosis condition. And if the only one you have is in a hospital, you can imagine going to a hospital 32 times versus going to your dermatologist's office. It's kind of a pain. The alternative offered by IntraOp is what they term as hospital-grade electron therapy within the dermatology clinic, which is a term I really like. And it brings a much smaller footprint machine that only generates electrons, 6 MeV electrons, into the dermatologist's office. It requires a much smaller space than a full service linear accelerator does. And as a result, requires much less shielding as well, not only because the space is smaller, but also because it generates much fewer high energy photons through radiation leakage. And as a result, the cost of the entire system is a fraction of what a full service linear accelerator would cost. And it's much easier to place in a dermatology office relative to the other one, which is really not possible. It offers a treatment time of around 20 seconds per patient in terms of what we call beam on time. It offers field sizes of up to 10 centimeters. And the beam this generates is identical to the beam generated by the $5 million machine I just showed you on the previous slide. So the actual quality of the beam is the same, and all the results and data supporting the use of electron therapy are applicable to this machine because it's the same beam. It has some really slick characteristics. The cone, which you see moving around there on the head of the machine, is actually made out of a high density plastic. It only weighs about 1.5 pounds, which it is markedly lighter than the alternative on a full service linear accelerator. In addition, with the machine, IntraOp provides 38 different shapes of cutout inserts that go inside the cone and that allow us to treat tumors or target volumes of really any shape we want, from rectangular to oval to circular to anything in between. As I said, the maximum field size is about 10 centimeters, but typically most of our field sizes in practice end up being between 3 and 4 centimeters. We also have the option of on-screen lead, or excuse me, on skin lead to sharpen the beam edge even further, although the penumbra with this device is really quite good, better than what you get with a full-service linear accelerator. IntraOp has also developed a laser reflection device within the head of the machine that allows measurement of the SSD directly from the laser onto the patient's skin. It is displayed on the front of the machine on an LCD for the therapist to easily read and set up the patients when they deliver the treatment. All this technology has allowed us to really have a very streamlined approach, and we can treat, we found between 7 and 8 patients an hour with this technology quite easily once the therapists are up and running with it. And that's a real tribute to how well this machine has been designed. You definitely could not achieve that type of throughput with a conventional linear accelerator. SET in the dermatology clinic, as Dr. Casper alluded to, it is exciting. It allows for true multidisciplinary care. It puts us as radiation oncologists in the same building as a dermatologist and gives a really neat synergy there. It allows the radiation to be delivered by radiation oncologists, which I would argue is a better and better option for the patients than having the dermatologists try to do it, just like they wouldn't want me trying to do Mohs on them. It involves a team of radiation therapists and medical physicists, which my company SET Solution oversees as part of our total package. And we together make use of our best clinical expertise and partnership to deliver patient satisfaction to these dermatology patients. We follow very rigorously NCCN, ASTRO, AAD, and AAPM guidelines in everything we do. And our billing is also very straightforward, as Jim will talk about in his next talk. In summary, radiation therapy is well proven. It's nothing new. It's an excellent option. It's supported by national guidelines. As radiation oncologists, I think most will strongly agree that electron beam therapy has some significant advantages over other forms of radiation therapy for skin cancer. The IntraOp technology is really unique and allows cost-effective deployment of SET within the dermatology clinic and brings this technology to a lot more people. And the SET model is really a new model that we're excited about that has demonstrated a great ability to provide non-surgical options for patients with really focus on collaboration, cooperation, and quality. And so with that, I will conclude, and I'm happy to take any questions that the audience might have.
Great. Thank you, Dr. Brabham. That was excellent. It looks like there are a few questions, and I know that in your talk just now, you covered a few of them that were posted previously, but it looks like there are a few follow-ups to those. So there had been one about lesions, and it says how many sessions are typical for one lesion?
Sure. So yeah, that's the fractionation question. Usually we find we're treating anywhere between our two most common fractionation regimens are 55 gray and 22 fractions, or 64 gray and 32 fractions. We trend towards the longer fractionation and in truly cosmetically sensitive areas such as the face, or delicate areas such as the scalp or pretibial locations. That ends up being a lot of what we're treating, because cosmesis is a big driver of patient demand for this. And all those fractionations are daily. So every day, Monday through Friday, 5 treatments, 5 fractions per week.
Okay, thank you. Another question that came in was, this machine, is it more complicated than X-ray machines? And how is the uptime?
Sure. So it is a little bit larger, and I'm not an engineer, but it is a little bit more complicated, has more going on than a KV X-ray machine for sure. But that being said, it's much simpler than a full-blown linear accelerator, and it's actually very well designed. Uptime has been excellent. Our uptime numbers are above 99%. I think have only had one day in which we could not treat in the 6 months we've been operating now, something to that degree. So uptime has been excellent, and IntraOp and their service team are always available, and we interface with them all the time, and been very pleased with how it's run.
Thank you. The next question, what recurrence rates do you expect for the patients?
So recurrence rate, that depends on a lot of factors, the size of the tumor, whether it's a recurrence, whether it's adjuvant therapy, whether it's a de novo cancer, the grade of the tumor, et cetera, et cetera. But if I were to summarize for kind of the most common thing we treat, which is a T1 squamous cell or basal cell carcinoma, the literature supports local control rates in the range of 93 to 95% for those type lesions, and that's the majority of what we treat.
Okay, thank you. And here is another one, and I believe this might be the last one. Since 1997, no large randomized studies have compared surgery and radiotherapy for NMSC. With the emergence of new technologies, isn't it time for a new study? And do you have hopes with the arrival of FLASH therapy?
Sure. So there's a lot in that question. First of all, as radiation oncologists and oncologists in general, we love randomized trials. So a randomized trial for this technology would be great. It would be hard to do, I think, in the United States, just because Americans have historically shown a reluctance to be randomized in trials that involve surgery. So they either want it or they don't want it, and they don't want that decision to be made by a flip of a coin. That's true across all of oncology, and so maybe our European colleague could chip in with that. But if we could achieve that, that'd be great. In terms of FLASH, FLASH is really exciting, and I know IntraOp is very excited about FLASH as well. The technology is largely the same in terms of physical technology of what the machine we're talking about today. It has great potential to revolutionize not only the field of SET, but of radiation oncology in general. But there's a lot of data pending on that, so stay tuned in the years ahead.
Great, thank you. That looks like all the questions. And yes, thank you for joining us today, Dr. Brabham.
My pleasure. Thank you.